So welcome everybody to our first Pine session of the 2025 year. So the ATS Pine webinars are the Pulmonary Infections Network of Experts. These are some webinars that we have been doing to try to help create awareness about different respiratory infections and really try to have our experts weigh in and provide some additional input on the management and diagnosis of these conditions. So today we are fortunate enough to have multiple experts in the field of NTM for this ATS Pine presentation. So today we're going to have Dr. Sanjay Devarajan, who's going to be presenting our NTM case. He's an assistant professor at Baylor College of Medicine. And then we have expert commentators today, Dr. Sebastian Kurtz, who's at Yale as an associate professor, and Dr. Shannon Kasperbauer at National Jewish as an associate professor as well. So welcome, everybody. We're in for an exciting case. And for everybody, if there will be some audience response questions that feel free to participate throughout. And then if you have any questions, please put them in the comment box and we will try to address those as we go on through the case. So thank you and take it away.
All right, fantastic. Thanks so much, Ashley. And thanks to Dr. Kasperbauer and Dr. Kurtz for serving as our experts today. So without further ado, we'll get started. I'm very, very excited to be here. So first off, disclosures, I do serve as a consultant for Insmed Incorporated, which will not have a bearing on my talk today. So let me give you a quick summary because there's a little bit of complexity baked into the cake with this patient. So this is a 60-year-old gentleman who has a history of connective tissue disease-related ILD, diagnosed by VATS biopsy back in 2002. And that biopsy, which was not immediately available to us, did show chronic fibrotic ILD with possible UIP, does have a history of gastroesophageal reflux disease. And this patient essentially for about a year after the biopsy was managed with immune suppression, unfortunately developed right lower lobe pulmonary MAC infection, which was treated for a year with 3-drug therapy. We believe that was clarithromycin, ethambutol, and rifampin. And seemingly actually had recovered, stopped therapy after a year, and essentially was followed as an outpatient by an outside pulmonologist at another large city in Texas. Unfortunately, in August of 2014, he developed an episode of massive hemoptysis out of nowhere and actually was hospitalized and required an emergent right lower lobectomy, and actually did fairly well after that. Unfortunately, ended up with a MAC recurrence while he was on immune suppression and needed 15 months of the same 3-drug regimen he had been on prior. And essentially after that, his lung disease essentially continued to progress from the standpoint of the ILD. He was apparently having more fibrotic changes in the airways, in the lung parenchyma. He was starting to need oxygen situationally. This is a very, very active guy who started needing oxygen with exertion. In 2023, he started an antifibrotic. And around this time, he actually started to develop more B symptoms. He was starting to have loss of appetite, chills, malaise, cough, sputum, and then unfortunately he ended up with some quite a bit of diarrhea related to the antifibrotic, which I know many of us are sort of familiar with. So he started to get more of like an advanced lung disease workup, ended up with the right heart cath, which showed elevated right pulmonary arterial pressures, mean pressures, as well as a fairly normal wedge. So he had a fair bit of precapillary pulmonary hypertension, which was treated by a PH expert with inhaled tadalafil, started pulmonary rehab, and then he was worked up at his local center for lung transplant, thought to be too complex, and he was referred to Baylor St. Luke's, which is the transplant center that's associated with Baylor College of Medicine. These are a snapshot of his PFTs. We really were lacking a lot of older data, so you see there's a lot of nearness, proximity to a lot of these tests. Essentially when he started undergoing transplant workup. And as you can see, he has a pretty significant vital capacity decline at 48% predicted, and the DLCO is about 48% as well. So pretty advanced disease. And I hope the video works, but this is images from his CT chest from just about a year ago. Hey there, it's working great. And so for sake of time, you kind of notice the patulous esophagus there. There's a lot of scattered consolidations and nodularity, a lot of peripheral cystic changes. And then you start seeing in the right lower lung field, you start seeing a couple of cavities, and this is particularly large in what used to be the right lower lobe, and it's just in the right lower lung fields now, and quite a bit of honeycombing. And I did mention sort of the patulous esophagus as well, so he has that component to his phenotype. Any thoughts or questions about that CT from our experts? Otherwise, I can keep moving.
I just would say it looks very interesting because we know he has connective tissue disease associated ILD, but it's a striking asymmetry here, which we sometimes see with IPF, right? Just want to point it out that the right lung looks much more smaller than the left, and looks like, part of the more, I don't want to say cavitary. Yeah, well, there is a cavity actually,
Yeah, and keep in mind, he did have that emergent right lower lobe removal, so that may explain some of the mediastinal shift and the chest wall changes.
Okay.
Okay, great. So now this is when, things start getting relevant to this group, which is as part of his transplant evaluation, we obtained sputum cultures, and he essentially had two positive AFB cultures, smear negative, but positive cultures for M. abscessus, subspecies abscessus. He had two isolates, one of which was smooth strain, one of which was rough colony. I'm showing you his M. abscessus sensitivities. So I guess perhaps not too surprising for a subspecies abscessus. So overtly, clarithromycin resistant. You do see susceptibility to amikacin, clofazimine, imipenem. So in this case, not intermediate. Linezolid, and tigecycline. So this is going to be the next. This is going to be the question for the group. So what's the next step in management? So you should see a poll pop up. So please do vote.
Oh, thank you. I'm going to open this over to our experts now to weigh in kind of on the prior imaging and culture results. What are some of the things that you guys really start thinking about in these patients who have had prior NTM infections and now with really concerning rapid growers? What are your next steps you often think about in the workup?
I'll jump in, Ashley. Thanks. So, I'm just to go back or think about your slide on the microbiology. So he's grown this multiple times, correct? The abscessus.
He initially had, Dr. Kasper, he had MAC infection with the recurrence in 2018, but
right.
these would be the first isolates for M. abscessus.
But more than one date, right? He's had multiple days of positive abscessus. So he has cavitary macrolide resistant abscessus and, concurrent symptoms. I mean, this patient needs to be started on therapy. I definitely wouldn't pursue watchful waiting in this gentleman. He's quite compromised. I haven't heard if he's still on immunocompromising medications or have those been held.
No longer.
Okay. Yeah. So unfortunately, the drug susceptibility panel is very typical for our subspecies abscessus, and you're lucky because at least it looks phenotypically like he has oxazolidinone susceptibility. We see that in maybe 20 to 30% of our isolates for what it's worth. But this is a very, typical M. abscessus subspecies abscessus that needs to be on ideally 4 drugs. So that would be our next steps. And the second question about additional workup, Ashley, Sebastian, did you want to chime in on that?
Well, I think you hit on it, right? The question is, are there any other modifiable factors, that could be contribute? You mentioned, I think, something about in reflux and things like that, which we always pay attention to, and which is fairly common in this advanced lung disease. The question is how much of that is modifiable. I think we'll probably very familiar with like airway clearance and things like that, which I think is going to be helpful. My question in that regard is, if you have such a structurally abnormal lung and the lesion, especially cavities, look to be very peripheral, how much you get out of it. But on the other side, I think thinking about airway clearance, minimizing reflux, it's essential to try to protect other areas of the lungs that the infection is going to be confined and not, spreading around.
Yeah, I agree. I think doing a reflex evaluation in this gentleman would be important. Even, monitor checking for oral pharyngeal dysphagia, swallowing abnormalities, that would be important to look at in this patient. And just our standard, which I'm sure you've already done, the other comorbidities, quantitative immunoglobulins, alpha-1 testing, et cetera. Unfortunately, some patients have more than one etiology to their underlying structural airway disease.
Okay, great. And it looks like 82%, if I saw that poll correctly, selected A, which is, I believe, the right answer. So essentially the way that our transplant center works is there's a transplant infectious disease team, which is kind of separate from our NTM clinic, that actually manages the transplant, those patients that are in the transplant world. So he initiated multi-drug therapy. He essentially was admitted for a PICC line. He had 3 drugs that were started. He was started on imipenem, celastin, tigecycline. They did give him 25 milligrams and ramped up to 50 milligrams a day and pre-treated with ondansetron, and was actually started on linezolid 600 milligrams a day. I'm not exactly sure the thinking behind this particular regimen. I can't really speak to it, but I did, you do notice that there was no amikacin as part of this mix. There was no use of azithromycin for its potentially immune modulating. But, be that as it may, this was the drug regimen he was started on. Unfortunately, not long thereafter, he actually developed thrombocytopenia, and then he developed quite a bit of GI symptoms, which became quite horrific to the patient. He had a lot of nausea, vomiting. He was having upwards of 10 episodes of diarrhea per day, loss of appetite, and essentially required a brief hospitalization to rehydrate, rule out C. diff colitis before moving forward. So he actually was, given this medication intolerance, he was actually referred to our NTM clinic. And when we had seen him, he actually looked, he had basically stopped all therapies just because of all of the side effects. So he actually looked quite healthy at that time. He was thin. He did have a normal saturation, was not on oxygen, had kind of those classic fibrotic basilar Velcro-like rails at the lung bases, no wheezing. Didn't have any edema, and he did have some mild digital clubbing, which he says had really been long-standing for him, so may have been familial. So shortly after, this foray into antibiotics land, he essentially the tigecycline and linezolid were discontinued. 3 times a week IV amikacin with higher peak values were initiated. He established with our clinic, where we really focused a lot on adjusting his antibiotic regimen to something that could be palatable to him. Like Dr. Kurz had mentioned, we did kind of think it was important to initiate airway clearance in this patient with bronchodilation, hypertonic saline, and positive expiratory pressure therapies. How valuable is it in somebody with interstitial disease and traction changes as opposed to kind of more of a mucopurulent-driven bronchiectasis? That was one of the questions that we had when we initiated these treatments. And then his regimen with us was so amikacin, imipenem, celastin, and oral clofazimine. These labs, so his CBC with differential and CMP were within normal limits. Unfortunately, we didn't end up getting an ESR, and I do agree with you, Dr. Kasper-Bauer. I think he's due for some immune globulin testing. He did have an autoimmune workup, however. He had a weekly positive ANA titer previously in 2023, which we repeated and was negative. His rheumatoid arthritis evaluation, ANCA, Sjogren's disease evaluation were all negative. T-spot and HIV were negative. Interestingly, he did have a positive MI2 beta antibody, which, because I'm sadistic, that's going to be the next question to ask you all, which is a positive MI2 beta titer is associated with which autoimmune condition?
So as everybody's thinking about the associations between autoimmune disease and bronchiectasis and chronic lung disease, just wanted to kind of pose over to our experts to weigh in. Given this patient's significant side effects that they had experienced with prior treatments. What do all of your centers perhaps do to try to help counsel some of these patients on monitoring and side effects as they're going on to treatment?
I'll jump in. So I would say the first thing, is that it's very easy to frustrate your patient when you start them on tigecycline, right? So if I have a patient who, and I preemptively give those patients, if I'm not able to get omadacycline and I'm treating them with tigecycline, there's a lot of antiemetic use in our program. But fortunately, it's been easier to get patients on omadacycline, at least in our experience. So even, using IV omadacycline, as I've had more success with that than IV tigecycline. The oral omadacycline, I'm certainly seeing GI side effects from that. So if I have to use a tetracycline, I'll try to use omadacycline. I also would have used amikacin up front, but everybody gets an audiogram. They all get extensive counseling about fullness in their ears, tinnitus, hearing loss, trouble with balance, and then we're monitoring audiograms monthly while they're on IV aminoglycosides. Fortunately, the imipenem is generally well tolerated. Some patients will have that week of flu-like symptoms for the first week of treatment, but oftentimes that improves and they're able to stay on the beta-lactam. And then the clofazimine, it's a matter of not if, but when they're going to have some bronzing of their skin. I'm starting to take more photos of patients who are on this to counsel individuals who were consenting, because I think when our patients hear about clofazimine and they go to the literature, they see the worst images of lepromatous lesions with severe, black pigmentation, and it's really not that bad. Most of our patients tolerate it quite well. We've published this. Our discontinuation rate on this drug was 14%. So compared to all the things we do, I think clofazimine is one of the easiest to tolerate drugs that we have.
I agree with that. I had good experience with clofazimine also, but I have a question for you, Shannon. I had at least 2 patients, I believe, with complex connective tissue diseases that also had involved the skin to start with. And they did develop like a truly intolerance to the clofazimine with worsening, skin rashes, not just the color change, but they did have really like dermatitis kind of pictures. Have you seen that with clofazimine in people who just have a higher risk of developing skin problems from the connective tissue disease to start with?
I do have actually a dermatomyositis patient right now on clofazimine, and I can say that in the areas where he has skin involvement, he's also a dark-skinned individual, but he is, having hyperpigmentation of those lesions. But it really is, it's tolerable. It's a cosmetic issue for him. He's elected to stay on it because he knows it, should eventually fade. So I haven't had anyone that has had to stop. I've had people without prior, connective tissue disease involving the skin who've had ichthyosis and just intolerance to clofazimine. They've just had to come off of it. So the answer is not, can't think of anyone off the top of my head, but I'm sure it exists. And you have to counsel patients. When we start, our practice has been when we start noticing that tanning, we cut their dose in half. We go from 100 milligrams a day down to 50 milligrams a day. And that usually allows for a plateau of that hyperpigmentation. And it also helps with some of if they're having dry skin or itchiness, it definitely helps with that as well.
Got it.
Great. Ashley, are you able to see the poll there? I'm not able to see what the responses were.
I don't see the poll on this one. So maybe if you want to just go through this one, Sanjay.
For this one, sounds good. Yeah, so the correct answer is dermatomyositis, and this is kind of interesting. It's a situation in which these antibodies are directed against helicase, which is kind of fundamental to a lot of the cell division processes. Only about 20% of dermatomyositis cases have a positive MI2 beta, and actually it's compared to other myositis syndromes, it's actually less associated with development of ILD, which is kind of interesting in relationship to this case. It is associated with skin lesions and proximal muscle weakness, but it has an overall good prognosis in when immune suppression is used, which unfortunately for this patient is complicated because of the underlying infection. So the summary of the case so far is that, this patient meets ATS-IDSA criteria for treatment of M. abscessus lung disease. He initiated treatment back in March of 2024, and actually, despite side effects and a lot of changes to the medication regimens, he has had persistently negative cultures since May of 2024. And he's been submitting samples every 1 to 3 months since then, all of which are negative. In the long run, the plan was to pursue lung transplantation for interstitial disease. So for this one, this is the question that I think everybody is probably hopefully asking themselves, and I think many of us ask all the time in these clinics, which is for lung transplantation candidates undergoing treatment for M. abscessus, when is it safe to list for lung transplantation specifically? So if we can generate the poll for this, I would be very curious.
Thank you. This is definitely a loaded question, so I'm very curious to see what our experts have to say on this, just given the difficulty of treating these infections. Sebastian, do you want to start?
No, it is a difficult question, and I think, of course, you want to achieve negativity, right? You could start looking at, all right, how effective has my regimen been in obtaining the negative cultures, right? Did they convert within 3 months, or did they take them longer to kind of get the sense of the trajectory, how effective that is? Having said that, if you ask me to pick a letter, I would say I'm not sure, but I would pick C. 6 months. Which allows us to make sure that's a sustained culture conversion, right? That's the other thing. You want to make sure that the cultures stay negative for a certain period of time, that you don't have a reemergence of positive cultures.
And I'll throw my 2 cents in there. So I know that we're probably going to go into this Delphi study in a moment here, but and I know what it recommended, but I honestly, I think that this is a very individualized question, because if we have these standards, which we really have no data to support what is the optimal duration of culture negativity for these patients, but if we held them to these standards of having to have a certain amount of months with culture negativity prior to transplant, most of my CF patients would never have had a transplant, because this is really, it's an incurable disease. So, I think what I'm looking for is that a patient's on effective treatment, they're tolerating treatment, and they're improving. But just that one variable of achieving culture negativity, I don't know that has to occur for the individual to be listed. And again, this patient's even more complex because he has multiple cavities. He's had prior thoracic surgery, so he's a lot of adhesions, and the cavities are really pleural based. So this is going to be a very tricky transplant for him, and you have a much greater risk of seeding the pleural cavity, and then again potentially developing skin, soft tissue, and bone infection with abscesses thereafter. But my answer is I don't think we know. I chose E because I think it really needs to be individualized based on each case.
And just to add to that, what you're saying is, which I think is very I'm very agreeable to, even if you don't find it in the sputum, it would be unlikely that these peripheral cavity is going to be completely sterile, right?
Right.
And that was a question I was going to have for the experts, which is that in terms of regression of the cavitary lesions, how are you looking at that before, not giving your blessing, but perhaps considering that this patient can move forward with transplant? Do you need to see improvement, or are you really looking at culture negativity above all?
I'm definitely not. I mean, again, I think, like I said, it's individualized on the patient, but this patient, just by looking at that initial CAT scan, is high risk. With the fact that he's had prior surgery, the fact that he has these large, thick-walled cavities right up abutting the pleura, versus a patient who just has bronchiectasis and nodules, no prior surgery, and yet is still culture positive despite being on treatment. Maybe they're not smear positive any longer. That would be an important goal, to make someone smear negative. I think, we know from our non-transplant literature, in patients that go to have lumenectomy or lobectomy and they're smear positive, they're more likely to have poor outcomes. They're more likely to have a BPF. So I think that is a reasonable, goal for these patients. But what I'm trying to say is that I wouldn't make culture positivity an absolute contraindication to having lung transplant. And I don't think his cavities are going to get much better with his underlying architectural disease.
And I like the way you bring that anatomy here on the table to the discussion, because yes, when we think about resection in usually cavitary NTM disease, we want to make sure that the airways are as sterile as possible. So that's where the smear status comes into play. I think using inhaled antibiotics like inhaled amikacin is going to play a role here to just keep that area where the surgeon's going to cut the bronchus, got to be as sterile as possible. But as you pointed out, here we have a very peripheral cavitary process, which has a high risk to spill over in the pleural cavity. So I think definitely something to be concerned about beyond, as you said, culture and smear status in this case.
Yeah, and you can see, looking at the polls results here, is that there's a fair bit of nuance to this. Well said, both of you. So yeah, this is the answer. Nobody knows. If you haven't seen this SNL skit, this is one of the greatest skits I've maybe ever seen. There's two of them, so make sure you look at this George Washington skit on SNL from the last couple of years. It's too good. So we've got the comments going. So I wanted to, move forward with the discussion. For this group, I mean, mycobacterium abscessus, it is perhaps something you deal with 5 days per working week. So we don't need to get too much into the background, but for those that are new and trainees, this is a bacteria that, as Dr. Kasper-Bauer mentioned, once patients have active infection, and certainly cavitary infection, it is sometimes rendered an incurable disease. So it's really challenging. The therapy is typically individualized. A lot of times the patients are, for lack of a better word, frail or fragile, with a lot of comorbidities, setting them up for infection. But treatment is guided by our ATS-IDSA criteria, drug susceptibility, and then there's a lot of issues with respect to drug-drug interactions and patient tolerability, all of which was relevant with this patient. The overall success rate of therapy is low at 45% and is particularly grim when you're dealing with macrolide-resistant isolates. So there's a little bit of a misnomer on this slide. Mycobacterium abscessus is not really a complex as much as it is a singular bacteria with multiple subspecies. So the three subspecies for abscessus are subspecies abscessus, Macilliense, and Belletti. And Macilliense, making that distinction, and this is something after hearing Dr. Kasper-Bauer talk, hearing Dr. Daly talk, and when you see it in the real world, is that a lot of times labs will not report the subspecies, which is very, very important if they report, susceptibilities. But Macilliense is substantially easier to treat because it tends to have a non-functional gene, so that macrolide susceptibility is maintained. So that's a big plus when you're dealing with Mycobacterium abscessus if you have a Macilliense isolate. And as you can see from the map here, which is sort of inherently flawed because this really is based on reporting, but it's thought to be more of like a southern sort of coastal type of bacteria that lives in the environment, particularly in soils and the water supply. If you get your water from city pipes, there's a very good chance that there's going to be a biofilm of mycobacteria in that piping. And sometimes it's difficult to counsel patients on how to manage that, especially when they have underlying risks. As you can see down in the bottom right, Hawaii has the highest prevalence of M. abscessus of all the U.S. states. And without further ado, we'll keep moving forward. Treatment is, again, if you have a macrolide susceptible isolate, it does, provide you with a greater likelihood of treatment effectiveness. But in this case, patients who have inducible or mutational macrolide resistance, the guideline is to use a multi-drug regimen with at least 3 active drugs. And often azithromycin is continued to be used despite the resistance due to its immune modulatory effects. And we tend to, although we don't have great data for this, we tend to use sort of the MAC approach and treat patients for 12 months from the point of culture clearance. So that's why getting very frequent cultures is important in these patients to set your time to grow. And, there's been, I think there's a lot of interest in the literature on mycobacterial in general. And I think we're learning more and more about what drugs we can use and what the cut points are for with respect to susceptibility. So here on the left-hand side, you can kind of see the overall kind of overall therapies that we'll use in combination to treat these bugs. And they all have variable cutoffs in terms of MIC with respect to sensitivity and intermediate response to by the bacteria, as well as resistance. So in this case, the guideline would suggest that the initial phase for a macrolide resistant M. abscessus species really should involve an initial phase and a continuation phase. And the initial phase is ideally 4-drug therapy. So 1 to 2 parenteral or IV therapies, and then 2 oral therapies, including azithromycin. And then once you get to the continuation phase, the idea is that you treat these patients for 3 to 4 months with this initial phase, and then you transition them to something that's more palatable and tolerable, so using 2 or more drugs as tolerated by the patient. So I think this is the final question for the group, which is acquired mutational resistance to which antibiotics is associated with worse prognosis in M. abscessus pulmonary disease? So if we can launch the poll, that'd be great.
So thank you so far for sharing. It's like all the MICs is like that people can get back on their cultures. I was wondering if our experts could kind of weigh in on how they typically approach looking at the variable MICs, knowing that there really is only a handful of drug MICs that have really been well studied and validated for use to guide kind of some of our treatment regimens.
So really this is kind of easy to remember because, the 2 drugs that are really important for MAC are the same 2 drugs that are important for abscessus, as far as what we see in vitro correlates with what happens in vivo. So I don't know if you want to answer the question before I go on, but
You're already right.
Yeah.
So it's F. It's C and D.
C and D, right? So that's what we really pay attention to. And I know we're very spoiled here at National Jewish, but within 24 hours of an isolate growing, we know, what it is by molecular ID, and then, what the mutational resistance shows. So right away, I get a report that says if it's subspecies abscessus, if I have a T28 sequevar, and for people that are new to abscessus, most of our abscessus has inducible macrolide resistance, and that is because of the gene, the ERM41 gene. And that gene, most of the time, has this thymine at position 28, which allows for an active gene. But every once in a while, we get really lucky, and there's a switch from a thymine to a cytosine at position 28. So we call those favorable isolates C28 sequevars. And all that means is that the macrolide will work in that patient. And unfortunately, that only happens about 15 to 20% of our abscessus. But those strains behave like Myciliense. Myciliense actually has an ERM41, but it's truncated, so it's not functional. So really and I love what you said, that it's important to know what you're dealing with, what type of abscessus are you dealing with. But if your lab isn't giving you this lovely 24-hour information, know that the reason why you want to know the subspecies is as it relates to this one characteristic. How does it behave in the presence of the macrolide? So truly, if you're not able to get that, it can be a moot point. I mean, you just need to know, is your lab holding that isolate for 14 days and telling you whether or not inducible resistance is there to the macrolide? That's just as good for now as knowing which subspecies, at least from a treatment standpoint. There may be other questions from an epi standpoint or relapse or reinfection questions, but I'll pause there. And do you want to say something, Sebastian? Do you want to tackle the amikacin question?
I think I agree with everything. I know for MAC, it's really, we're not even looking at other MICs, right? If there's an ethambutol MIC, we're not supposed to look at it. Also understanding that most of these cutoffs are imported from the TB literature, which just behaves differently. I think for abscessus, given that it's a fast grower, it's kind of, you can glimpse at other MICs for the other drugs, but it's still hard to make a decision on it because for most of these drugs, we do not have this clinical correlation with outcomes. For the amikacin, I think it's fairly similar to what you have said to the mutational resistance with claritomycin. I think if you have your mutation in your ribosomal RNA genes and it's highly resistant, it's probably hard to overcome. So I think there's a pretty good correlation between the MICs you're seeing on the plate and the mutational resistance you're seeing.
Mm-hmm.
Just when you look at the MIC table in general, you may be familiar looking at your classical gram-negative antibiogram, where you want to see an MIC for imipenem of less than 1 or less than 0.5, whatever. And here we're talking about 4 and better. So it's just we're seeing a much higher range, which also means it's going to be much harder to attain the target concentration with an outpatient regimen that is also doable. So I think in that table is the challenge of finding this effective microbial regimen very well depicted.
Yeah, and microdilution, the methods that we use for those of you that are ID, like this process is tricky, right? Because these organisms replicate slowly. We're holding them in these wells for days, and certain drugs degrade, right? And so, for research studies, we're having to top off the wells to make sure that we're continuing to have that steady concentration of the drug in the well. But that's part of the why this is so fraught with difficulty for mycobacterium MICs.
Great, we can keep moving. Thank you for the comments. Yeah, so it looks like most people put C and D, so you're right. Unfortunately, rifampin, for the one person who put B, rifampin doesn't really have a role here. So I did want to, take a moment just to talk about, or maybe a little bit more than a moment, to talk about this bit from the guideline, which is essentially patients who are needing salvage therapy. Essentially, you're not able to, perhaps they remain smear positive, they remain culture positive, remain symptomatic despite guideline-based therapy. It says you use parenteral imipenem with ceftaroline or ceftazidime and combine with the best oral and inhaled agents. And I wanted to sort of get into this a little bit, and I think this could be a really good topic for discussion, which is the role of dual beta-lactam therapy. This is something that's, I think, garnering more and more attention. I think since, I would say for the last 6-7 years, when I reviewed the literature on this, you're seeing a lot more in vitro data being published on this. And the idea here is that abscessus, on top of how difficult it is to treat, it has a chromosomally programmed beta-lactamase inhibitor, which is called BLAMAB, which is a great name for an enzyme, if you ask me. And so there's a lot of interest to see is there a way to overcome the beta lactamase inhibitor. And so Jacco van Ingen, who wrote a paper last year, which did a lot of, it's actually reviewed the data on this. And for those who have never seen him speak, he's quite a character, and he has walk-up songs when he speaks. When I saw him, he played Welcome to the Jungle by Guns N' Roses, so he got the crowd riled up. Not bad for a microbiologist, but the data on this is interesting. So there actually are beta-lactam and beta-lactamase combinations that show pretty decent in vitro synergistic promise against M. abscessus, specifically tebipenem, avibactam, and imipenem, relebactam. And there's also use of dual beta-lactam agents that show in vitro synergism: cefoxitin, imipenem, ceftazidime, imipenem, ceftaroline, imipenem. And how do these work? This also comes from Dr. Van Ingen's paper, where he basically compiled the literature. And what you see here is if you focus on the green, if it's light green, that means there's some data. And if it's dark green, there's actually a fair amount of in vitro data to support its use. So if you look at, for example, ceftazidime, which on its own has very little to no in vitro activity against Mycobacterium abscessus species. If you start combining beta-lactamase inhibitors, and if you use ceftaroline, for example, which is another beta-lactam, you actually start seeing some in vitro benefit there. So I think this is like sparking a lot of interest. There's really no randomized trial data to guide us here, but there's a lot of really interesting in vitro data to show that for salvage therapy, once you're sort of getting beyond guideline-based therapy, initiation of dual beta-lactam therapy could have some promise. This is another interesting paper that was published in MBio in 2019. What these guys did was they looked at 30 different M. abscessus isolates, so including subspecies abscessus, macilliense, and belletti. And I want to give you an example of how this can work. So if you looked at ceftazidime here, in and of itself, these MICs are very, very, very unfavorable across the spectrum. Okay, so the MIC 50 is at 256 and the 90 is 512. So just totally hostile. This abscessus is very hostile to that type of antibiotic. But if you were to use higher dose ceftazidime and you actually combine that with ceftaroline, you see a dramatic shift, in vitro shift, in these MICs towards a much more favorable antibiotic impact against the organism. So I think we don't have to discuss it right now, but I would love our experts' opinion on their experience using this. Actually, this might be a good time to discuss before moving to the next topic.
So I can comment on that. I still have some ties to one of the labs in Cleveland who has been doing a lot of these studies. And, the background, how this came about is actually, I think, was a lab at Rutgers where they wanted to check avibactam and combine with imipenem. And since it's only compounded with ceftazidime, they used that and thought, the avibactam is a good inhibitor of the beta-lactamase, but they had to do like the control experiment. So they used just ceftazidime and combined with imipenem, and as you can see on the table, it was pretty effective. It was kind of counterintuitive because, as you pointed out, ceftazidime on its own doesn't have any effect. It is a little bit a similar biological phenomenon people may remember in treating enterococcal endocarditis. We say like cephalosporins don't have any activity against enterococcal. It's kind of classic teaching. But if you combine, I think it's ceftriaxone plus ampicillin or something like that, you see some sort of synergism. So not to go too much in the detail of the synthesis machinery of the beta-glycan, but that's what mycobacterial have, similar to gram-positive bacteria. They have this beta-glycan mesh, and they have an additional set of enzymes in addition to your classical penicillin binding proteins that lead to some alternative cross-linking. So what we think, if we use two different beta-lactams, that they target different parts of that highly complex synthesis machinery. And in fact, there are a couple of case reports out there now we had used it on one case with a highly resistant recurrent M. abscessus. We used ceftaroline together with imipenem, and we were able to achieve culture clearance with that. So there are a couple of case series out there.
Yeah, not a lot, but we're starting to see more. I agree, Sebastian, and it's exciting to see people publishing their experiences because I hear you, it's being used for sure. No one really knows the right combination or what exactly to use. My experience has been more because we had Khalid with us, we used ceftaroline and imipenem together. And I've had both skin, soft tissue, and pulmonary abscessus patients that we've treated. Unfortunately, the skin soft tissue developed severe thrombocytopenia on the combination of two beta-lactams, and it precluded us from treating him with that cocktail. I know Chuck has a spine case that he's treated successfully. I've had some pulmonary cases. So, I think you're right. We need a randomized controlled trial. We need data to really evaluate this. And I think we have to be careful too, because as we've learned from Dr. Bonomo's lab, the combination that's going to work for different strains isn't universal, right? It may be that for one strain, it's amoxicillin imipenem, and for another strain, it's ceftaroline imipenem. So I think that there's some nuances to this that we probably need to prepare for.
Fantastic, thank you. Okay, as we enter the home stretch here, so I in my fellowship training, I trained at a program at Baylor, which has one of the largest adult cystic fibrosis centers in the country. And what I was always taught was that essentially, if you have a CF patient, and I think Dr. Kasperbauer made mention of this, if you have a patient with CF who develops mycobacterium abscessus colonization, even that's a patient, should they need transplant, is probably not going to get it at your local center, and will probably have to go to a far-flung center where there's more expertise. And so, doing this case kind of enabled me to kind of look at what data is out there. And we don't need to go into all of this in detail, but there's a lot of retrospective case series on these retrospective cohorts, which looked at experiences at various transplant centers or conglomerates, and how they managed their patients who were looking, staring down the barrel of a lung transplant, and had mycobacterium abscessus. And, as you can see here, I think, it's definitely a problem. I think, without a doubt, I think, especially when patients are going to be put on a lot of immune suppression, the nature of the surgery, developing skin and soft tissue infections related to that bacteria, and certainly pulmonary infections is possible. I was kind of struck, like this UPMC series actually showed us that actually the complications can occur fairly rapidly, like within the first couple of months after transplantation. And that the rates of that can be pretty high. So the Canadian experience was that more than half of patients recurred post-transplant. And while there was a higher mortality in that group, that wasn't statistically significant. And it did seem like those that were eradicated prior to transplantation did have a survival benefit. But, when I looked at this, to me, it seemed like if these patients are sort of perioperatively managed well, there's a plan in place to treat them, and perhaps treat them for an extended period, if possible, post-transplant, the outcomes actually seemed not too different from other patients undergoing lung transplantation, which is, of course, a hazardous procedure, no matter how you cut it. So I think, we obviously sort of need more data. I don't think this is a population that's ever going to have a randomized control trial done. It's mostly going to be retrospective data that we look at, but I think it sort of ties into the next questions, which kind of tied into the audience poll question, which is, how should we manage these patients? And as Dr. Kasperbauer had alluded to, this is a paper that was published in 2023 using what's called a modified Delphi approach. So to me, what amounts to getting a bunch of smart people together and figuring out hard questions, the answers to hard questions. And so this slide shows you, this group was sort of extensively polled and using a Likert scale. So the scores went from -5 to 5. The responses went -5 to 5, where -5 is a strong sort of disagree with the statement, and a 5 is a pretty strong agreement with the statement. So up top, you can see this is actually related to MAC, so a little bit different than what we're talking about. But during the pre-transplant stage, patients with MAC infection who are currently on treatment and who are sputum culture negative can be listed for transplant if, most people strongly disagreed that it's contraindicated, which is of course right. But there was a fair amount of agreement whether, that they should be sputum culture negative for a certain period of time, but somewhere in the 6 to 12 month range. That was kind of my takeaway. So patients should be at least 6 months out, most people thought, and definitely everybody thought that if they were 12 months negative, they should be listed. So it's a little bit more nuanced when it comes to M. abscessus, just because of the complications associated with it. And so when polled, there were a few more people who thought that lung transplant was contraindicated compared to those with MAC, although not a big difference. But there was much more agreement to sputum cultures being negative at 12 months. They didn't actually report the question about whether 6 months was appropriate. But it seems like most people agree that if they have been sputum culture negative with Mycobacterium abscessus infection, that they can be listed. And with respect to what antibiotic regimen that's used, suffice it to say, most people said if azithromycin or macrolides are available, use those. And then there was a fair amount of agreement across the spectrum with what antibiotic combinations to use in the non-cavitary patients, assuming that the isolate was susceptible to all antibiotics. So flipping back to this patient as we wrap up here, currently he's tolerating a regimen of IV amikacin, oral clofazimine, and linezolid. We are, just to reduce the burden of the IV amikacin because of hearing issues, we're trying to transition him off IV into inhaled amikacin as an off-label use. He actually is listed for bilateral lung transplantation. He's more than 6 months out since his last culture positive, or rather his first culture negative. And he's actually actively receiving offers. He received an offer this week, as a matter of fact, which didn't pan out, but I think it's just around the corner. And just one real quick plug for the Baylor NTM program, which is it's small but mighty. We started a couple of years ago. We're pretty unique to the Texas Medical Center. It's a multidisciplinary program. Dr. Hamdi is my colleague who's on the call here from infectious diseases. We're very, very tied to thoracic surgery. We've had a couple of really interesting multidisciplinary cases with thoracic surgery to date. And we're trying to get an RT to join the clinic to help us with airway clearance teaching. If you're interested in the program or you want to refer, just Google BCM NTM. We'll be the first hit there. And that's the email to the clinic. And that's all I've got.
Thank you, Sanjay. I did want to open up a question for the experts. Like, now that we've talked a little bit about dual beta lactams and kind of next steps in M. abscessus treatment, I guess is like just knowing kind of some of the current literature. I'll start out with a question on any thoughts on kind of up and coming studies looking at phage for NTM, specifically looking at some of the CF studies that have looked at this in pre and peri-transplant patients.
Yeah, our colleagues here at National Jewish, Jerry Nick, is the PI on the post-stamp trial, which is the multi-center sort of compassionate use phage therapy for patients with CF. So we are, it's actively enrolling at sites. So I hope that I'm very grateful that that's happening, and hopefully we'll get some information from that. It is a very complex process getting phage for a patient. I don't know if you've employed this, Dr. Lozier or Dr. Kurtz. I have someone on phage right now. It takes about a year to get the entire protocol approved and to get a match and to make sure that the patient is ready to go. The good news is that once they're on phage, it's very tolerable. I mean, there's really, from my experience and not published in the literature, I'd say the biggest hurdle is the port infections that patients get because they're accessing a port twice a day, every day, doing home infusions of the phage. But, I think that it's an exciting field, and hopefully we'll learn more in the near future.
I think we just have one question in the chat that I saw, and this is kind of a common question that we kind of come up with from patients, but particularly just to Dr. Kasperbauer, looking at environmental samples from patients' homes. Kind of do you guys have any routine recommendations for samplings, particularly in some of these, let's say, M. abscessus patients?
I mean, the short answer is no. And I think that, until we have better data to say that it kind of changes outcomes in patients, we're not routinely sampling people's homes. I mean, we tell people to try and avoid high-risk environments, but Dr. Kurtz, are you doing that at Yale?
No, we say the same, and they still go to Florida every winter time. So,
Dr. PJ McShane was in Houston last week and gave a grand rounds, and she presented some of Tyler's data because they are doing this.
Mm-hmm.
Unfortunately, she said the hit rate, that is like matching the species, has not been very successful. It's actually in the single digits at their center, and they had like 90 or 100 people that they had tested.
and I wanted to point out, especially in CF and M. abscessus, there's some exciting epidemiological literature that is actually a clonal phenomenon appear to be the case. Like they isolate like similar like cell clades or clones that spread apparently from CF center crossing continents. So it sounds like this environmental where's the infection coming from gets another complex layer when you look at CF in particular. So there may be a person-to-person spread going on, actually.
Well, thank you again to all of our experts and our presenter today for going through this really challenging case. Like, we know that these infections are really difficult to treat, and there is a lot of nuance to it. So I think having this opportunity to review these cases, and also potentially seeking out some of your local expert centers to try to get these patients some of these medications that can be so challenging to get, can be really important. So thank you again. And just to let everybody know, there is an upcoming Pine session on February 13th at noon Eastern time. And that's actually going to be looking at the colistin Promise 1 and Promise 2 trials for a journal club. So exciting things to come. And thank you guys for kicking off the 2025 year.
Thank you much for having us.
Thank you. Bye-bye.